allow people to come in for a few moments. We've had quite a busy week this week with Dairy Women Ireland. We had a crowd go to the Charleville factory to look at the cheese production of cheese strings, milk infant formula. It was very interesting, and also the dryer. So yeah, it's interesting to see Charleville with 2 million litres of milk a day, and from those million litres of milk that can turn into 100 ton of powder. So yeah, it was interesting stuff. Anyway, tonight we're on Let's Talk Menopause, and I have the pleasure of joining us Fidelma O'Mahony. Fidelma actually graduated in University Cork, and she trained as a general practitioner, but then she had a bit of a change of career and went for obstetrics and gynecology, and that's when she was appointed after that a consultant in obstetrics and gynecology and senior lecturer in medical education in Staffordshire and Keele in the UK. From that, in 2019, she was appointed the hospital dean and honorary, I can't speak tonight, I apologize. Good job, I'm not giving it, professor. And clinical education. Look, our interests are in urogynecology, perineal trauma, pediatric and adolescents gynecology, and menopause. So we have got a huge amount of wealth of knowledge behind this presentation. And if we can, we'd like to, make it as interactive as possible. So rather than just myself asking the questions, now I am a 45-year-old, and I do have a wee bit of perimenopause experience, unfortunately, so I have a few of my own. But if you, at any point you have any questions that you want to know, or things that just queries that trying to understand yourself, please dive in, or things you've seen. So we're going to get started. Thank you very much for joining us, Fidelma, and for your time, and I'm going to let you to roll away. So if you
okay, right, well thanks ever so much, Mary and Alva, for organising this. I have to say I'm never good on Zoom meetings, even though I do loads and loads of them. I do them at the university, and I do them at the hospital, and I do them with lots of organisations, mainly dealing with women such as yourselves who are not doctors. So this next slide, thanks very much, Mary, pass it on, next one.
All right.
So this slide sums up an awful from my practice, because I see young girls coming in the horrors of starting their periods and not coping, accompanied by their mothers who are heading into the horrors of menopause and not coping, accompanied by the grandmothers who are getting prolapse and have just operated on them. So it's not unusual for me to have 3 generations of the same women in my clinic on a day. And I like this slide because I would challenge any woman of any age to say that she didn't feel like one or more of these at any time in her life, because I know I certainly do. I might call it different things, but I think this for me sums up life in lots of ways, and I rather acknowledge it and embrace it. I think, next slide, please. I think, do you want to move on to the next slide if you can, Mary? Or shall I wing it?
It's gone. Hopefully
Is it not doing it? Yeah, right.
So why is menopause important?
That's great. So listen, so why do we talk about this? Well, historically nobody talked about menopause. And the more older I get now, the more I realise that years ago I remember my mother, I remember my aunts, I remember relatives when I was a young child, and I thought they were the moodiest and oddest bunch of people in the world. And of course I had absolutely no idea of what they were going through, and also of the fact that they were getting absolutely zero sympathy from either their families, their husbands, perhaps their certainly not in the workplace, if any of them were still working. And they were very much left as an isolated thing. And women talked about the change. And I think the change is a good word because it completely transformed how you feel. And it completely undermined everything you feel and everything that empowers you as a woman. And you got no help. So nowadays, we are better at looking at it. But modern life brings more expectations and more demands. And whereas a lot of our mothers, or in some of your cases, grandmothers, may have been homemakers exclusively, now most women are going to be working through life. They're not going to have the pleasure or punishment, whatever way you want to look at it, of being exclusively a mother and a homemaker. So they're always going to be out and working. And this is very much the case for rural women, where work on farms sometimes isn't recognised as an employment. And then they are expected, you know, and I think this is where we put our own expectations on. We put a lot of expectations on ourselves to perform well and to look well and to behave in lots of ways and be illustrating eternal youth. And then we've got the demands of jobs, of life. You know, most households need 2 incomes to survive, to pay for life, to pay for education, to pay for everything. So hitting the menopause is really, really a key crisis point for a lot of women. So next slide, please. Okay, so I think the other thing to think about, that, you know, 100 years ago, women only lived until they were about 50, and now we live until we're 83 or thereabouts. So we have almost half our life from menopause or perimenopause through menopause. So it's not just about period stopping, it's about all the health issues that women have that can be exacerbated by the menopause, and what are we doing about it. So actually menopause should be a time where we look at our health and say, you know, what can I change? What can my doctor change? And unfortunately, a lot of us have to push their doctors to get that change, but we can talk about that later on. Okay, next one, please. Okay, so again, a little bit about the definition. And the reason I don't normally like definitions, but a lot of people get hung up with definitions. And actually, and the big issue is between menopause and perimenopause. And menopause is if you've not had a period for more than 12 years. Perimenopause is from when you start having symptoms until 12 months after your last period. And the difficult thing about this is that if you are unfortunate enough to be talking to a healthcare professional who doesn't specialize in this or hasn't got a lot of experience in it, they don't appreciate the perimenopausal symptoms because women are still having periods, and they then misdiagnose them, and you get sent in all sorts of directions with problems that may be genuine other health problems, but may also be menopause symptoms. So again, years ago, the average age of the menopause was 50-51. Now it's 52-53. And we define early menopause as if you have menopause before 45, and premature ovarian insufficiency, which used to be called premature menopause, that's if it happens before 40. And that's important because when we talk to women and about the risks of taking HRT, if you have an early menopause, you're actually only replacing with HRT what you would normally have until the age of 50 anyway. So the risks aren't the same. Yet the health risks, the risks of HRT aren't the same, but the health risks are very, very much increased in terms of your heart and bones. And then the other group we see are induced menopause. So these are women who've had their ovaries removed. Maybe they had an ovarian torsion where the ovary twisted. Maybe they had a cyst. Maybe they had cancer treatment, and not necessarily a gynae cancer, but it could have been pelvic cancer radiation as a child. Maybe it's chemotherapy. And I've just seen my first typo, and apologies, spelling is not one of my talents. I can do a lot of things, but I can't spell. Next slide, please. Sorry, Mary, I stopped you earlier. Right, okay. All of you will recognize these symptoms because this is what people have. And yes, if you have gynecological problems, if your periods stop, if you have hot flushes, if you have sweats, you get vaginal dryness, you have pelvic floor problems, GPs and healthcare professionals are very good at diagnosing menopause. However, if you start getting things like aches and pains and stiffness, or you break a bone, you know, sometimes menopause gets a bit missed in that one. So it might be that we have to think about other causes, but also think about menopause. Next one. Okay, and this is where the difficulty begins, because we have estrogen receptors in pretty much every area of our body: our brain, our skin, our bones, our heart, our genitals, our breasts. So the symptoms of menopause affect everywhere. And if I had £1 for every woman who came to me really, really angry because she got mood swings, she got irritability, she got lots of mental health type problems, and her doctor said, oh, this is depression, have an antidepressant. It may be depression, but it may all be menopause. And if you have never had these symptoms before, and you're in your mid to late 40s, and you start having these for no other reason, think about menopause, even if you're still having periods. And similarly, the general type of things: fatigue, breast tenderness. Women report tinnitus when they get buzzing in their ears, skin changes, eye changes, and hair loss. And the biggest one that worries women is weight gain. Now, these happen at menopause time. The challenge with these is that taking HRT doesn't always cure these. You have to look at lifestyle things as well, and I'll talk a little bit more about that. Next one, please. So I mentioned earlier how menopause impacts on women, and you know, in the workplace it's often a bit of a joke. We all make jokes about it, but if you look at well-run surveys in groups of women who are of menopause age, almost half will say it's affected their work and they had to take more time off. And I've come across women who have had to give up work because they couldn't stand up and, you know, present at something or do something with sweat pouring off them or becoming bright red. It's really difficult. And that's the sort of embarrassing symptoms. What about things like muscular aches and pains, fatigue, insomnia? A third of women will say they feel like they don't want to go out. They feel they're not good company. They're feeling isolated. And actually, I think they are isolated because of those issues. Over half of them will say their sex life is affected. And that's not a surprise, but it's something that often isn't asked about. When I talk to my medical students about this, it's quite interesting because a lot of them think that sex stops at a particular age and it's age related. They get quite surprised when we talk about women and their sexual activity at all ages in life. And about, you know, almost a half will say their partners are affected. And actually, a lot of men will say, I'd like to help her, but I have no idea what to do. Anything I say is wrong. And the surprising bit in this statistics is that it's only less than a third have arguments, because I can tell you, I see women and I think their lives are a complete battleground because of menopause impact. Now, I do realize I see the ones who are more severely affected, but it's an issue. So the big question is HRT the answer? Well, I would put it to you that it is part of the answer, but the biggest problem I see with HRT is not advising women on what HRT can do, next slide when you're ready, but the limitations of HRT. So earlier I talked about the demands we're under. We get bombarded. So 10, 15 years ago, there was a huge scare about HRT and breast cancer, and loads of people were saying, I can't possibly take HRT, it's going to kill me, or my doctors told me I can have it, but I have to only have it for 5 years. Now, in the last couple of years, since that sort of media scare, a lot of the studies and the research that have underpinned that decision have been looked at again and reanalyzed, and we now know that's not the case. Next slide, please. However, that has given us the opposite extreme. We have all these celebrities who are out there breaking taboos. And if you look at any of these celebrities who are either writing books or on television or producing videos or doing book tours about menopause, they have one thing in common. They're all extremely well off, they're all extremely glamorous, they're all extremely thin, and they all have had an awful lot of work done. And I do doubt what some of them take. So yes, they sort of peddle this image of what women should be aiming to be like between the ages of 45, 55, 60 or whatever. And I feel they don't help women because they are actually trying to sell us a very unrealistic expectations. So I think it's good that people are talking about menopause, but just beware of everything you read and hear, other than what I say, obviously, because that's gospel truth. Next one, please. Okay, so what about HRT? Okay, so HRT improves the symptom of menopause and it improves general health. And there is a lot of research to support that. And if anybody's interested in it, the website to look at is Women's Health Concern or the British Menopause Society. But there is a wealth of evidence to say that it does us good. It is safer than we previously thought it, but it still has some risks. And it's not for everyone, which is why it should be a medical issue. One of the problem areas I have when I see my patients, and I've seen a lot of them who bought their HRT online, and we don't know what's there. Also, we have to acknowledge that it won't cure your pre-existing health problems. Next slide. So when you look at what you should have, in terms of HRT, the two main ones to think about are estrogen and progesterone. If you have got a womb, if you have not had a hysterectomy and you have a womb, whether you have periods or not, you need to have estrogen and progesterone because estrogen alone will cause cancer of the lining of the womb. However, if you've had a hysterectomy, you can have estrogen on its own. And some women who have a hysterectomy for endometriosis may still need to have some progesterone. So nowadays we look at estrogen in patches, sprays and gels, and these are much, much safer than the older tablets. And the progesterone we use tends to be tablet patches, tablets which are the bioidentical ones. We use the Mirena coil, which is a contraceptive coil, but also has a small amount of progesterone in it. And some of the patches with estrogen have also got progesterone. So these are all the first line ones we prescribe now and are much, much safer than the older ones, where a lot of the older studies that showed risks were on the old tablets. In terms of what type should you have, well, if you still have your womb, if it's less than a year from your last period, we would say cyclical HRT. So that's where you have estrogen throughout your cycle, progesterone for 12 to 14 days, and you'll probably carry on having bleeds. If it's been more than a year from your last period, you can have your estrogen and progesterone continually, and that hopefully will result in no bleeds. Testosterone is very much an individual choice and discussion thing. I might have time to discuss it and I'll answer questions if need be, but it's not currently licensed for women apart from one particular type, which is generally only available in the private sector and costs an awful lot of money. So how long should you have HRT for? Well, if you started around the age of 45, it's the first line management for menopause symptoms, and there is no doubt that the benefits are clearly there for taking HRT until the age of 60. After the age of 60, we do continue. I've got a woman of 95 who takes HRT, but it's about discussing the risks and the quality of life. And for this woman at 85, she tells me, I don't care about the risks, but I feel great, so give me more. And as I said earlier, if you have premature ovarian insufficiency, if for any number of a host of reasons, and there are numerous, you stop your periods before the age of 40, the earlier that you stop them, the longer you should take HRT, and at least until your 50s to mimic what nature will give you anyway. Next case, blood tests. So I see a lot of women who get a bit angry because their doctor hasn't given them a blood test. In my book, if you're greater than 45 and if you have symptoms that could be due to menopause, and unless you've got breast cancer, there is no reason why you can't have some HRT. So why bother with tests? What I would do is I would just make sure that you're on the right dose, and I would probably only do tests if you were on the maximum dose of HRT and you still had symptoms. If, however, you're young, if you're under 45, and particularly if you're under 40, I would want to certainly do lots of blood tests to check if there's any other medical cause for you stopping your periods that early. So I think I would do blood tests in that situation. And if a woman comes to me saying, look, I'm on HRT, my libido is still awful, and we go through a full consultation on it, I would want to check her testosterone levels before I actually give her testosterone. Next slide, please. Okay, so everybody asks about the risks and they are genuine. So the biggest risk we worry about nowadays is breast cancer, but we need to get this in perspective. So if I have a woman who has got breast cancer, I'm not giving her HRT. If I've got a woman who's very high risk of breast cancer, I probably won't give her HRT, even though I have some individual cases. And if I have a woman who has a strong family history of breast cancer, we'll discuss the risks, but we'll look at it in terms of her lifestyle and what she's having. So the risk of getting breast cancer in women between the ages of about 50 and 59 is 23 in 1,000 women, right? If they're on HRT, that gives you 4 extra cases. If you're on estrogen-only HRT, it actually helps protect you from breast cancer. But if you're on the contraceptive pill, that's the same risk as taking HRT. If you drink alcohol, and let's face it, most of us do, that gives you a risk of breast cancer similar to having HRT. If you're a smoker, it's a similar risk. And the biggest risk for having breast cancer above the basic population risk is actually having a raised body mass index, being obese. And in that case, you have 24 extra cases per 1,000 women, which is far, far in excess of the 4 extra on HRT. So when we discuss breast cancer risks, we look at everything else. We also talk about the risk of getting breast cancer as opposed to the risk from dying from breast cancer, and that's an area that is changing. But at the moment, people say that even if you do get breast cancer, your chances of dying from it is not affected by HRT, and these are very much individual conversations. In the past, we thought if you had a clot or stroke, you shouldn't have HRT, and it still says that as a risk on the information leaflets. However, that refers to the old-fashioned tablets, and if you're on the new patches or gels, there are absolutely no increased risks of having a clot or stroke. However, if you're overweight, if you're a smoker, if you're immobile, you have a high risk of getting a clot or a stroke anyway, or a stroke rather. So overall, the risks of having a complication on HRT, a life-threatening one, are there, but lower than thought previously. Next slide, please. So I think it's good. I think it works for most people. It gives symptom relief from the hot flushes and sweats. It helps with quality of life. It improves your bone health. It improves your heart health, and it also improves sexual function. But what if you can't take HRT? What do you do then? Do you want to move on, please? And this is where I feel that the celebrity issues don't look at the wider picture. So irrespective of whether you actually can or can't have HRT, there are certain things that really exacerbate hot flushes and sweats, and they're smoking, caffeine, and alcohol. And it's a really hard conversation to have with a woman who says, I've always drank 7 cups of coffee a day, and you say yes, and you didn't get along, you got on fine, but now you are perimenopausal and your body is metabolizing this differently. So caffeine will give you hot flushes and sweats, and it will cause sleep disturbance and fatigue, as will alcohol. So we recommend about 10 to 14 units of alcohol a week, and not all in one go. So I have women who tell me, well, I only drink at the weekend, but they have 2 or 3 bottles of wine, which is 18 to 20, 30 units of alcohol over 2 nights. So that actually is going to bring their symptoms back. We know that mindfulness therapies such as cognitive behavioral therapy and yoga, they help with symptoms. Antidepressants, I did say earlier that antidepressants are something that a lot of women get given and feel fobbed off for, but actually if you are a breast cancer sufferer and you can't have HRT, or you carry a breast cancer gene and you can't have HRT, and you have mood swings and depression and anxiety, antidepressants may very well be for you, and there are lots of other drugs of a similar nature. You should also look at your heart as you're getting older and what can you do? And also think about the fact that even though, apart from some types of breast cancer, even though you can't have HRT classically, you could perhaps have vaginal estrogen. So if you've got problems with your bladder, problems with your pelvic floor, pain on intercourse, local estrogen cream or pessaries could be considered. So think about that. And also we talk a lot about specific moisturizers and lubricants that are good for women post-menopause. And again, I can talk a little bit more about individual things if we have time for questions. Next slide, please. So as I say, if you have medical problems or you're perimenopausal and you can't have HRT, or even if you do have HRT, you need to look at everything. You need to look at your symptoms. You need to look at the family history and look at all the health issues, not just gynecological ones. Next slide again. And this is what we mean by saying it's a time to modify health risks, not just one thing. So, heart disease. Everybody thinks, it's interesting, when we survey people and ask them what you think the biggest killer of women is, they all put down breast cancer. And in fact, the biggest killer of women in the Western world in the years after menopause is heart disease. The risks of heart disease goes up dramatically for women after menopause. And often women don't get diagnosed as quickly, because a man goes along, clutches his chest, says, I feel a bit funny. Everybody thinks you're having a heart attack. Women goes along, say, I'm feeling a bit funny. They say, oh, it's probably a panic attack. It's probably your time of life. It's probably just the change. You're probably worried about something. So we have hard evidence to show it's changing now, thankfully. But in a lot of cases, women don't get diagnosed as quickly with a heart attack as men do. And they often haven't had the same sort of aggressive treatment. And there's also a risk of getting diabetes after menopause. So what can you do apart from HRT? Well, stopping smoking, reducing your sugar and salt, having a healthy weight. And if you can have HRT, HRT does have benefits for the heart because it reduces the bad lipids and cholesterols. Next one, please. So you sit there and you wake up one day and you can't move and everything just cracks. And we have all had mornings like that. Or maybe you're all incredibly healthy compared to me, but I have a hell of a lot of mornings like that. So what do we do about it? Next slide, please. So when we think about bones after the menopause, and in particular when we think about osteoporosis, everybody thinks about women. And actually, 1 in 2 women will have a broken bone. But up to 1 in 5 men will have it as well. So it's actually not just a problem for women. So it's a problem for all of us. Next slide. And to prove the point, this is my own personal x-ray of my fractured hip. And I thought, because I'm pretty fit and pretty active and I climb hills and do all sorts of sporty things occasionally, that it would never happen to me. But I had a really simple tumble and ended up with a hip replacement. So, you know, it can happen to everybody. And I was doing everything I should do, but I still ended up with not full-blown osteoporosis, but osteopenia and breaking a hip. Next one, please. So what can you do? Well, weight-bearing exercise is really good. Having an appropriate body weight. In the past, when I was growing up, it was felt that really thin people were unhealthy and very overweight people were fine. Nowadays, we actually realize that people are overweight. They carry as many health risks for your bones as being underweight. Calcium, vitamin D, I think in this part of the world, we should all be taking vitamin D, certainly throughout the winter months, and most of it should just take it all year round. The recommendation is 400 units, but I take 1,000 units, and well, you know, it's not going to do any harm. Smoking is directly related to bone mineral density loss, as is unfortunately excess alcohol. And I must admit at this stage that when I talk about this subject, menopausal health, I realise I'm a complete killjoy, and I realise that when I've finished it, the first thing I want to do is get a glass of wine, because I've spent so much time telling people stop drinking. Focus on the positives. Exercise, it reduces bone loss and it improves bone strength. In early years, and I don't think it's ever too late to start, high impact exercise is good. However, in later years, high impact exercise isn't good for your pelvic floor. So if you're somebody who's experiencing urinary or prolapse problems, be careful about exercise and see a physiotherapist to get some bracing techniques first. But exercise will reduce your risk of heart disease and your risk of diabetes, and there is some evidence of it reducing your risk of breast cancer as well. This is general population, but not individuals. Right, I'm a good fan of yoga. I think it improves your balance, and that in turn reduces falls. And I know I did fall, but I think I would have been worse if it wasn't for it. It helps your core strength, and that's really good for managing your pelvic floor and helping with sexual function and with incontinence and prolapse. It improves your muscle tone. So if you are unfortunate enough to have a fracture and a fall, it does mean you'll get back on your feet better, and you're more likely to get back to a full recovery rather than be on the slippery slope downhill. And the other thing about it is it's absolutely brilliant for mental well-being and psychological symptoms. And it's because of the way it calms your brain and helps you slow everything down through positions and poses and exercise. So it has a lot of positive benefits. This is a picture, which is the egotistical one, to show that you can come out the outside. And this is me 8 weeks after breaking my hip up a mountain. So, you know, it's not the end of the world if you do, unfortunately, have an accident. Next slide. So if I was to summarize what I've said, HRT is effective for menopause. It's much safer than we've thought before, and it's positive for your heart, well, not your heart, maybe your heart as well, heart, bones, for metabolism, and for your quality of life. However, it isn't a magic cure, and it is not an anti-aging device. It won't cure pre-existing diabetes, and it will not cure a broken relationship either. Next slide, please. And this is my happy slide to show that even if life does go downhill, you can still get out and enjoy things. And I think that is the end of the slides. So I realize I haven't covered areas like testosterone. I haven't covered areas like herbal remedies and alternative remedies and all sorts of other things, because I would have you here till Christmas if I did that. But I'm very happy to answer anybody's questions if anybody has any questions they want to ask.
Hello.
Hi, Anne.
Hi.
Great. How are you? That's very good. Well done. Good presentation, and I learned a little bit.
Thank you.
I know nothing about HRT. I'm lucky I don't have to worry about any of that particularly. But my question for Fidemla is, I've had Mirena in since I'm 40. I'm on my third one, and this one I got in at 50, and I'm now 57, and I was told I could leave it in for 7 years.
So the license, Mirena is licensed for two things. It's licensed for contraception and it's licensed for HRT. For HRT, it's 5 years. For contraception, actually, we say 8 years here now.
Okay. Well, it was for contraception, yeah.
Yeah, so that's fine. So now some people will say, oh, well, and I have had women who come along and say, well, you know, I went to the doctor and they said, well, it's there, it's not causing any problems, leave it there. But to be honest, if you're, you know, in your late 50s and it's been in for coming up for 10 years, I would certainly be taking it out when you're finished with this. That's my personal choice. I don't think it's going to do you any harm. There are some very rare situations where, you know, if you have pelvic inflammatory disease, it can cause a problem. But we want to ensure absolutely everybody has contraception till the age of 56. So certainly I would leave it in until it expires and then take it out.
Okay. And the follow-on question of that is, after taking it out, do people tend to go back to having terrible periods and things like that? Because
not in your late 50s. And because I feel that what stops the periods is the progesterone, and the progesterone is only licensed for about 5 years. So I think if that was going to happen, that would have started happening by now.
Okay.
Right. Yeah, but it does happen in younger women. And I have had the odd woman where they carry on bleeding and it's been in for 5 years. And I will say, right, I'll put a fresh one in.
Okay. Thank you.
Is there any more questions out there? Right, we have one. Someone's 55 and on 100 estrogel, 100
yeah,
and testosterone, but feel exhausted all of the time and have poor sleep. What should I do? Okay,
right. So first things first, when you say 100 of estrogel, the gel we go on pumps. How many pumps are you on? Because if you're on up to 2, you can increase it to 4. Or are you on a patch, 100 patch? So is it the gel? You're on 4 pumps. Okay. So if you're on 4 pumps of estrogen, that's the maximum dose. So if you're exhausted all the time, and I see a lot of women like that, what I would be doing first of all is I would look at other lifestyle things. Are you drinking shed loads of coffee? Are you drinking shed loads of alcohol? You change what you do with things like that. Are you getting some exercise? And you guys can all laugh at me. I'm used to people laughing at me because they say I'm on my feet all day. Exercise is not being on your feet all day at work. Exercise is something you take and you do it for you, not for jobs, not to get from A to B, not to take care of the children, the husband, the dog, the cat, whatever. So something like exercise. So if all of those lifestyle things aren't effective, I would look at your blood test. This is a situation I would check an estrogen level, because if the estrogen levels were very low, is there a reason you're not absorbing it? So for instance, are you putting it on the same area? Are you spreading it out properly? Are you letting it dry in properly? I've had a patient who used to put her estrogel on, and she said it some days it works and some days it doesn't. And I realized the days after going through everything she did, we realized that the days it doesn't were her busy days, when she basically got up and went and was running or jumping around the place and actually was sweating it all off again. So there are lots of different things like that. And then finally, there may be something else going on. Is there another problem? Are you anemic? What's your vitamin D level?
Yeah, so getting onto that, Fidemla, like, you know, obviously we've talked quite comprehensively about HRT, so estrogen and progesterone, but what about other elements? So vitamin and minerals, like what's the importance? Like, so we've got a bit on vitamin D, but like magnesium and things like that.
Right. So they're all very important. So vitamin D is crucial for your bones and your well-being. And people have told me that they felt tired without vitamin B. Magnesium is really good for muscle function and brain function. So people who are feeling depressed, anxious, low, magnesium is really good. And there's magnesium glycinate and magnesium citrate. So you have to see which one suits your set of symptoms better. Calcium again for your bones, and iron, and a good diet. So one of the things we all sort of look at cutting out things. If we're going to cut out anything, it should be sugar and fats. We need protein, loads of protein as we get older to keep our muscles and bones good. Most people don't have enough protein. Most people don't have enough fiber. So these are all part of a general well-being thing. They tend not to be as good at taking care of hot flushes, sweats, vaginal dryness, the pure menopause symptoms. So there is a place for them in general health, but they may, quite often I say to women, you need both side by side.
What about water intake? Some people would focus heavily on how many litres of water you actually consume in a day and the importance of that.
So water intake is important for 2 or 3 reasons. One is because we don't want to be drinking too many caffeinated drinks or fizzy drinks because they make hot flushes bad. But also, as we get older, an awful lot of us have either constipation or overactive bladder. And if you've got bladder problems, again, caffeine, fizz, dehydration make it much, much worse. We kind of say 2 litres a day, but that depends on what you do and what your lifestyle is. And if you're an elderly person who's very slight and not very active, well, 2 litres a day is going to be far, far too much. But if you're somebody who's running around a lot, you may need more than 2 litres a day. So it's about looking at what you drink, but water is an important part of it, yes.
Okay. So just to clarify, and please, ladies, if there's any questions as we go on, do just chip in either hand up or as the other lady did with just a question on the chat function. So yeah, so if we're sort of looking at the perimenopause and the menopause side, so the menopause is very much where you give serious consideration to put in HRT, but obviously there's this phase in the middle where we haven't a clue what's going on. We've gone from our normal cycles to, you know, getting a little bit irregular, sometimes a little bit heavy, changing in colour. Simple questions: can we still get pregnant? What are the symptoms that that people could, you know, expect and associate to actually being in the menopause that aren't given a lot of attention? For example, I was getting some visual disturbances, and obviously got them checked out and actually found out they were optical migraines, and migraines being actually a symptom of perimenopause. And I used to have migraines when I was young, but actually headaches, not losing vision. But yeah, could we go through those a little?
You could. So this is where the whole gamut comes into play, in that it is a huge, huge symptom set because estrogen receptors are everywhere. So my rationale is that if you are above 45 and you've got menstrual irregularity and other symptoms that are new symptoms, think, is it menopause? So, and with menopause, blood tests aren't very helpful at that stage because the correlation between blood tests and symptoms don't always tie very well. So if there is no reason not to try HRT and the woman wants to try HRT, I would say try it. But I would look at the lifestyle factors as well. So what I wouldn't do is wipe her off and say you're depressed and give her an antidepressant as the first line treatment. And a lot of HRT will help with menopause symptoms. So classically now, we would, for menstrual irregularity, if they're heavy, we'd put in a Mirena coil. That helps with the periods and it gives you progesterone in your womb. So if you then want HRT, you can have a patch or a gel and sort of titrate the dose to suit yourself. So you can treat it exactly the same as menopause. And if your migraines or your problems don't get better, then you think, actually, this isn't just menopause. If it doesn't suit you, it's not menopause. So you have to keep, there is a lot, there is an art to listening to what the symptom set is and looking at what this woman was like before. If they're, you know, if it looks like a dog that barks, it's a dog. And if you've never had these symptoms before and you suddenly get them at an age when we can expect menopause, think menopause as being part of the, don't dismiss it. That's my answer.
Okay. Just to quickly answer that perimenopause question, if you are still having periods, can you still get pregnant?
Yes, that was the last thing I was coming to. Yes, you can. So if you're having periods, you can get pregnant and you should carry on using contraception. And HRT, unless it's a Mirena coil as part of your HRT regime, is not contraceptive.
Okay, lovely. Okay, we have a question here. Recently diagnosed with inflammatory, rheumatoid arthritis.
Yeah.
Since they've started treatment, feel the menopause symptoms have intensified hugely. Is it in her head? Is it possible she's on 30 milligrams of
methotrexate? Okay, right. So first of all, none of your symptoms are in your head, right? You know, people say to me, I'm worried it's in my head. If you've got it there, you've got it there. Whatever the cause of it is ridiculous. If you've got a pain, you've got a pain. So the thing about menopause is you can get the symptoms of rheumatoid arthritis very much mimic the symptoms of menopause. And I've seen several women, in fact I saw one today, who told me lots of things are better, but I keep getting these joint pains. And she talked about small joint pains, and I suddenly thought, alarm bells, actually you have also maybe got something else. So it is a real challenge when you have menopause symptoms alongside something else, like rheumatoid arthritis, like say Crohn's disease, ulcerative colitis, one of these chronic inflammatory conditions. My answer to you would be, if you are certainly over 45, but if you're early 40s and you think you have menopausal symptoms and you've got rheumatoid arthritis and there's no other medical problem, have HRT. Because it's also good for your bones. And remember, HRT, a lot of women will say they feel better. And if you're feeling crap because you've got a chronic disease, you don't need to feel crap because of menopause on top of it. So actually, if we can treat the menopause, it may help you deal with the other parts of it much better.
Hey.
So it's not in your head.
So in that sort of vein, like if you like myself with perimenopause,
Yeah.
like actually going, say, for the Mirena coil in
Yeah.
that stage, is that a way of sort of a slight introduction of HRT?
Yes. So the Mirena coil on its own won't treat menopause symptoms apart from the heavy periods.
Okay.
But it gives you the ongoing progesterone, so you can then start introducing your estrogen to see if that makes you feel better.
Okay, and in that estrogen, obviously you've got oral, you've got obviously skin patches, and you've got vaginal estrogen.
Yeah. So you'd have your patches or your gels. That would be my first choice because they are much safer than oral. So they are the first ones to use. Vaginal estrogen will help with vaginal symptoms. It won't help with the hot flushes, the aches and pains, the mood swings, the general one. But sometimes you will have your HRT, have your progesterone, whether it's a tablet, a Mirena, or part of a patch. You have your estrogen and you get everything sorted, but you still have some vaginal dryness, have some estrogen in the vagina as well. Or with a lot of my elderly patients who have prolapse symptoms, pelvic floor symptoms, and they have vaginal dryness, they have their, 60s, 70s, 80s, 90s, they have vaginal estrogen. So yes, vaginal estrogen can be prescribed independently or in association with HRT.
But it might not just be vaginal dryness. It might be the fact that it assists, doesn't it, with incontinence, like if you feel.
Yeah, it will help with a lot of things. Yeah.
Okay.
So it's a whole gamut. Yes.
Yeah. Okay. How do you persuade your GP that you need to start making steps? Because again, even making that step to go to the GP with something that you feel off, but not specific, to exactly what's going on.
Okay.
How do you try and push the,
push the consultation? Yeah, that's a question I get asked all the time. Probably one of the commonest questions I get asked on the online menopause chat groups I do. So I always take the approach that it's better to try and meet them halfway. So I will go to them and say, look, these are what I've got. I think might be menopausal. And you say, actually, I've already taken some vitamin D. I've made sure I'm on iron tablets. I'm doing all the sort of good lifestyle things. I've cut down the caffeine. I'm still having these problems. Could it be menopause? Can I try some HRT? And if you say, if you've tried that, the other thing I often say to women, particularly if you've got a GP who doesn't know a lot about HRT, and let's say at the end of the day, they've got to cover every single thing. Quite often there might be a practice nurse there who is a bit more amenable, and have a chat with them to sort of pave the way. or you can just go to the pharmacy, try some Menopause, which is a multivitamin for menopause. And again, you can go and say, look, I've tried that. I've tried some herbal remedies. It's not helping. Can I have HRT? And then it gives them fewer options to fob you off, as it were. Because that's what people often say. Oh, it's probably your age. Just, adapt this, adapt that, try this, try that. If you've already done that, it puts you in a better footing to say, actually, I want to try some HRT. And I am seeing a big difference in the last 4 to 5 years in GPs' willingness to listen to the story and to prescribe.
Yeah. So, it's obviously, that's the starting place, I suppose, is trying to get yourself a little bit more informed about.
Yes.
Yeah.
And actually to realise that your symptoms might be due to menopause.
Yeah.
Yeah.
If there's any more questions, please feel free to put them up. But I'd just like to, at this stage, thank you very much, Fidemla, for your time and for the slides that you've put up. They've been very useful and very helpful and very insightful. It's a funny time of life, I suppose. It's all about change, isn't it? I suppose, being a woman, and for a while we don't always realize the change that's actually abreast of ourselves. So, again, talking to others, becoming more informed about what potentially happens and the stages we go through can be very useful conversation. And to know that, we can take a little bit of control of what we do and how we approach it. So I just have felt like to thank you for that and those times. So if there's any more thoughts or questions, please pop them up. But I think we're probably getting close to the finish with that, because our aim was for the hour. And apologies for the slight technical difficulties that we had as well. There was a bit of a delay from me switching over the slides to Fidemla getting them. So thank you very much for bearing with us on that side of things. So I don't see any more chat or hands up. So I think we'll call it quits. Thank you very much, everybody.
Great. Well, thank you again for inviting me. It's been really lovely meeting you all. So thanks a million. All right.
Very much. Yeah.
Bye. Bye-bye. Bye-bye.
Good.